Hi, I'm Dr. Wendy. I'm a pain physician. I worked in Hadassah University teaching hospitals for 12 years, and I led the treatment of musculoskeletal pain in the pain unit until about 5 months ago, where I stopped and I moved over to Asuta Medical Center in Jerusalem. And I'm giving a lecture now on treatment of shoulder pathology, particularly focusing on partial rotator cuff tears, and focusing on simple regenerative medicine techniques such as prolotherapy and platelet-rich plasma. Although I will touch a little bit on treatment of preventing recurrent shoulder dislocation as much as we can, and this can actually be done. So I want to sort of bring home a very important principle, and this really applies to the treatment of any part of the joint, part of the body that we're treating, especially when we're treating chronic musculoskeletal pain, because there are so many compensating mechanisms. So we really have to be very methodical. But if you really want to aim high, as my grandson here is as an archer, dressed up as an archer, if you want to aim high and get really good long-term therapeutic results, your treatment really has to be based on a very methodical, comprehensive clinical evaluation. And it's very important to understand that if you have a stress that falls on an area, whether it was from previous trauma or from faulty ergonomics or from faulty posture, those stresses don't fall on one little supraspinatus tendon or one little the ATFL ligament of the ankle. This applies to any part of the body, these principles, or on the iliolumbar ligament of the lumbar spine. It applies to a whole, stresses are fall on a whole region. It may be that the supraspinatus tendon will be the first to succumb, but if these stresses are completely continuing to be applied to this area, to fall in this area, then eventually the pathology will spread. The tears will spread and enlarge. And therefore, we really have to, if we can't correct these stresses that are falling on the area, you can't undo what's done with trauma. And the posture is irreversibly pathological, and we can't change that, then at least we can try and strengthen the whole area so that these structures will be better able to withstand the stresses that are applied to them. So we must address the whole functional unit. So we think rehabilitatively and not just one shot. And I really think that this is one of the failures of modern medicine. We just, tick-tock, do an injection here and send the patient out and expect them to be better. And very often they are better, but the pain comes back again very quickly, and it's no real cure. So we have to understand that the excessive stresses will fall on the rotator cuff tendons, the surrounding joints of the shoulder girdle, the ligaments. And we must remember that very often neck pain and shoulder pain go together. So if someone has pain sort of in the middle here, in the neck and this area in the shoulder girdle and radiating down to the shoulder, we should ask the patient, is the pain made worse with neck movements, or is it exacerbated with shoulder movements, or both? In addition, we should look at the thoracohumeral muscles, because if they're not functioning optimally, then we will get more stress applied to the rotator cuff, which I'm going to discuss soon. So we must evaluate all of these structures and treat them accordingly. At some stage, not necessarily all in one go. That would be inhumane to treat it all in one go, but at least to address it at some stage and to treat it, whether with physiotherapy, exercises, ergonomics, injections with platelet-rich plasma, whatever, to try and treat it. Preferably not with steroids. So the shoulder treatment of the shoulder has many, many challenges. It's a very challenging joint. First of all, it is the most mobile joint in the body. And this mobility comes at the expense of stability. You have a 3-to-1 ratio in the surface area of the head of the humerus versus the glenoid fossa. The glenoid fossa is very shallow, so you get very nice gliding and a lot of mobility, but as it is, like I said, it's at the expense of stability. Something else is very much ignored is that even though we know that there are 4 joints in the shoulder girdle, we don't usually address them, and they're very much ignored. We have the glenohumeral joint, we have the acromioclavicular joint, the sternoclavicular joint, and the scapulothoracic joint. It's not a real joint, synovial joint, but it actually functions like one. And if it doesn't function optimally, then that is going to add a lot of stresses to the rotator cuff. And something else that is very commonly ignored is that the shoulder, the rotator cuff muscles and the tendons are capable of referring pain down the arm, past the elbow, even up to the wrist and even down to the fingers. So pain that refers down the arm past the elbow does not necessarily equal nerve root pathology. And this is a very big misconception. So here are the pain referral patterns from the supraspinatus referring down. It can also sort of involve part of upper neck muscles going both anteriorly and posteriorly down the shoulder up to the wrist, whereas the infraspinatus, you can see, can cause also a bit of neck pain and pain down the arm, both posteriorly and anteriorly, and can involve even the thumb and the lateral 3 fingers. If we're looking at the basic anatomy of the ligaments and the shoulder capsule, you'll see here that first of all, the coracoclavicular ligament is very often injured. First of all, it's strained with shoulder dislocations. But if there's any history of a fractured clavicle or acromioclavicular dislocation or even sternoclavicular dislocation, that can have an impact on the movement of the clavicle and therefore on the coracoclavicular ligament. The capsular ligaments, the superior glenohumeral ligament, middle and inferior glenohumeral ligaments, all reinforce the shoulder capsule anteriorly mainly. And you have the fibers sort of intermingling and coalescing with the fibers of the shoulder capsule. Now, in real life, these fibers sort of don't finish at 1 millimeter and then the next one starts, the next one right next door. Everything sort of coalesces together. So these fibers will mingle in with middle glenohumeral fibers and so on with the inferior glenohumeral fibers, and sort of everything sort of coalesces together with the fibers of the shoulder capsule. Of these glenohumeral ligaments, the inferior glenohumeral ligament is the strongest and the most important in preventing dislocation of the shoulder, especially because the most common dislocation is anterior dislocation of the humerus. The coracohumeral ligament is very important in stabilizing the rotator cuff, and I'll elaborate on that soon. If you're looking at the ligaments from the inside, you're looking from laterally to the medial side of the joint, looking at the glenoid fossa. And you can see here these ligaments are mainly lie here anteriorly to strengthen the anterior shoulder capsule. So up here is the coracohumeral ligament. It's going off on a tangent to insert onto the coracoid process. Here's the biceps, long-headed biceps tendon. And here, depicted are the superior, middle, and inferior glenohumeral ligaments. You notice that these are the same colors as I have depicted them here. So you can see here that these are stronger anteriorly than posteriorly. They're almost basically very deficient posteriorly, and these strengthen the anterior capsule. You can see here they're depicted as slivers, but it's actually more than that. It's probably somewhere in between this and the previous picture, but they both all reinforce the shoulder capsule anteriorly. So you may ask, well, what about the posterior aspect? don't we need it posteriorly? So posteriorly, interestingly, the rotator cuff muscles are compensating for the lack of the glenohumeral ligaments that don't exist very much posteriorly. So here you have the subscapularis anteriorly, but posteriorly you have the supraspinatus, infraspinatus, and teres minor tendons that are part of their role is to reinforce and strengthen the posterior capsule of the shoulder. The acromioclavicular joint is very important when the capsule is weak. It can sort of lead to make the joint vulnerable to dislocations. If it is too tight, or if there's osteoarthritis and there is limited acromioclavicular joint movement, then that is going to put a lot of strain on the glenohumeral joint and on the rotator cuff muscles. We must be aware that each of the joints of the shoulder girdle, the acromioclavicular joint and the sternoclavicular joint, if they don't, they all move. And if they don't move, or if they're fused, or if they're osteoarthritic, or if they're injured, then that all has an impact on the function of the glenohumeral joint. So if someone has pain in the sternoclavicular joint here, from whatever reason it is, or from a previous dislocation or a fracture of the clavicle, then that also has to be treated. So if you're looking at the rotator cuff muscles, posteriorly, you can see the supraspinatus comes from above the spine of the scapula and goes laterally underneath the coracoacromial arch, inserting laterally onto the greater tuberosity. The infraspinatus muscle comes from underneath the spine of the scapula and together with the teres minor inserts laterally and sort of more inferiorly on the greater tuberosity as well. So each of the muscles plays their own role. The supraspinatus abducts, the infraspinatus and teres minor both laterally rotate, and the subscapularis, which we'll see soon, adducts the glenohumeral joint and internally rotates it. But that's not the sole role of these muscles. All of the rotator cuff muscles play a very important role in abutting and pulling the humerus onto the glenoid fossa, onto the glenoid. So if we have rotator cuff failure, what happens is that you get a net pull of the deltoid, pulling the humerus up, and that's going to work its way up to the acromion, and then you get a lot of friction of the tendons and wear and tear, and then tearing. So you can see that the infraspinatus and teres minor both pull the humerus medially and also slightly downwards. The supraspinatus pulls also medially and slightly upwards. So you can maybe wonder why, maybe if it's pulling upwards, maybe that's not so effective. But it turns out that the supraspinatus has the strongest force in abutting the humerus to the glenoid because it has the longest line of force, and therefore it's the strongest stabilizer. The subscapularis pulls slightly downwards and medially also. So there are several muscle imbalances. This is one I've spoken about now. This is when you get the pull of the deltoid with the humerus riding up as a result of rotator cuff failure, and this leads to rotator cuff arthropathy, which is really very hard to treat and often very, 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 very painful, leading to most of the time to an arthroplasty. But I'm going to show you some pictures with muscle imbalances, and I'm going to tell you what's going on in the first one, but I want you to look at the other ones and try and work out what the pathology is, which muscle is dominant or weak or just not functioning. So here, I'm just going to tell you, this is, we have a very dominant, tight, short, middle and upper trapezius muscle, the scapulary adducted, and the scapula, instead of lying between T2 and T7, it's lying between T1 and T6. They're too high. So this is going to limit the scapular abduction a little bit. But I want you to look at the other ones and see, try and work out for yourselves what pathology may be involved here. Which muscle is too weak or too strong? I'm going to let you look at that for a few minutes, a few seconds. And we'll discuss these soon. So there's three phenomena that are too often ignored. The first one we'll discuss is the fact that the scapula, we know that the scapula contributes 1/3 of shoulder abduction. If you have limited scapular abduction, then you're going to have more of the burden on the rotator cuff to achieve that range of motion. So when we're already testing for shoulder function, if you're already doing that, instead of, we should also already palpate the lateral edge of the scapula to see where it reaches, where it comes to. And you can see the scapular edge, the lateral scapular border should reach the mid-thoracic line. And here it's falling short of about 3 centimeters. So this is actually limited. And if that's going to be limited, that's going to affect the whole of the shoulder function. It's part of the cause of his limited motion here. Not the whole cause. He's got other reasons for that limitation. Another thing is here you can see this gentleman is standing with his scapulae abducted and his arms are medially rotated. Now I want to do a little exercise for you. I want you to all stand up, and just to impress upon you the effect of having medially rotated arms, I want you to stand up and abduct your shoulders right up to the top. And then I want you to stand up and really slouch forward, head forward, rotate your arms medially, slouch, really kyphotic. And then I want you to try and abduct your hands as much as you can, arms as much as you can. So obviously this is exaggerated, but you won't be able to abduct your arms to full range. Now I want you to do that again. Stand up straight and abduct your arms like you did the first time. And you will notice that when you get to about 90 degrees, your arms automatically laterally rotate. Now this is a present from heaven, because when the shoulder laterally rotates, the supraspinatus is able to escape the acromion. And therefore, we are escaping the impingement, the hooking of the that often on the acromion, and we can really prevent. We can escape a lot of the wear and tear that can occur to the supraspinatus. So, strengthening the infraspinatus, strengthening lateral rotation is very important if you want to really achieve good long-term results. And we will discuss that later on also. This lady, you can see, has very much anteriorly tilted scapulae. You can see that the inferior tip of the scapula is pointing outwards, backwards. Now the pectoralis minor is at fault here. It's very short and tight. It originates in the 2nd, 3rd, and 4th ribs and inserts onto the coracoid process. So if you're going to have a short pectoralis minor, you are going to pull your coracoid process down. The inferior tip of the scapula is going to be pointing out, and it's going to be aligned like this, like sort of that. And the problem is here that you will get a reduced subacromial space, so you'll get less room for the supraspinatus to move around, and you're going to get more impingement. So it's very important, if we can get it in time before they start having a lot of thoracic kyphosis, which often goes together. It's hard to say what's the chicken and what's the egg, but to really stretch that pectoralis minor as much as we can. Also maybe pectoralis major, but the pectoralis minor is critical. And that you really have to be very, very perseverant doing that. Okay, so I'm not going to go into the whole detailed clinical examination of the shoulder girdle. That is at another lecture, if anyone wants to see, on principles of examination of the peripheral joints. But here, so I want to talk about exposing the supraspinatus. If we're going to be sitting just by us, like with our arms by our sides, then most of the supraspinatus lies under the acromion. So we want to expose that in order to palpate it, in order to view it under ultrasound, and in order to inject it. So we can expose it in one of two ways. You can put them in the crass position with the arm totally medially rotated behind the back. But the problem with that is that most patients with rotator cuff pathology just can't do that. It's way too painful. It's challenging enough often to get them into the modified crass position with the arm on the ipsilateral back pocket. Even this isn't quite correct. It doesn't look the way it is meant to be, but it's meant to be with the shoulder sort of not just like this, but sort of extended like that behind the back pocket. And that will bring the supraspinatus tendon right out anteriorly like this. So you can see there's quite a bit of supraspinatus tendon here exposed, both anteriorly down here and laterally. So that's why it's important to sort of, when you're viewing it, not just to view one sliver, but to sort of go across and up and down in both longitudinal and short axis views. The literature, I'm not going to talk much on the literature here. I have lots of articles to show if anyone wants. But basically, steroids are good for the short term only. And not only that, if the steroid injections are repeated, very often patients fare more poorly than what they were off before they started the treatment altogether. So prolotherapy and PRP are effective in the longer term, at least 24 weeks. Some studies show more. Here's another study showing that platelet-rich plasma injections lead to significantly better outcomes in terms of pain and shoulder function in the long-term follow-up. In the short-term follow-up, PRP was superior only in terms of shoulder function, and I've seen that quite a lot. And obviously, when you're going to compare it to steroids, then you may not see a difference in the pain because we've just decided that steroids are good in the short term also. So injection points, I wouldn't inject all these points in one treatment necessarily. But these are points that I would like to inject over a period of time. Here's the Subscapularis insertion, the supraspinatus insertion, supraspinatus from the posterior aspect, infraspinatus and teres minor. I don't always inject teres minor. And if I want to treat a patient with recurrent dislocation of the shoulder, and believe me, patients get good results. They really stop dislocating. To at least, minimally, at least to inject both attachments of the inferior glenohumeral ligament, and best anteriorly. So the rotator interval. What is the significance of the rotator interval when we're treating the rotator cuff? So here, if we look at the cross-section of the rotator interval, first of all, what is the rotator interval? It's the area basically in the bicipital groove between the greater and the lesser tuberosities. Okay, so here we have the supraspinatus tendon here inserting onto the greater tuberosity, the subscapularis on the lesser tuberosity. Now, as I've said before, we don't have a tendon fiber just finishing here and the next millimeter having the coracohumeral ligament. It doesn't work that way. The fibers sort of cross each other and overlap. But here, so you have the tendons on either side. You have the coracohumeral ligament over the top. We're all talking about this is the intra-articular section, okay? So it's where the bicipital groove is a little bit flatter usually, not necessarily. Got the coracohumeral ligament over the top. You've got the lateral fibers of the coracohumeral ligament inserting onto the greater tuberosity, and the medial fibers inserting on the greater tuberosity, and the medial fibers inserting on the lesser tuberosity. And in the bicipital groove itself, you have the long head of the biceps and the superior glenohumeral ligament. Now, these fibers actually come underneath the long head of the biceps also and extend. It's not depicted like that here. So why is that important? So if you have a minor tear of the superior glenohumeral ligament, because that has a very important role in stabilizing, that makes the other tendons more vulnerable to tear. So you can have a minor tear of the supraspinatus, of the subscapularis. You can have both. Once you have one tear, then you're more vulnerable to tear the other and to tear spreading. And this is what I'm trying to bring home, that it's important to stress, not just to treat the supraspinatus, for instance. It's important to treat also the neighboring tendons. If the supraspinatus tendon tear is closer to the biceps insertion, biceps tendon, as in not distally but more medially, more proximally, then I would also inject the subscapularis to prevent that tear spreading. So now we want to view the supraspinatus under ultrasound. We're going to use this. We're going to have the patient with his arm in the modified cross position, with the arm sort of extended, not sort of like that, as the picture may sort of depict. And the probe is going to be longitudinal to the humerus, like this, pointing to the ipsilateral ear. And here you see, this is the imprint on the greater tuberosity. Here is the humeral head. Here is the black line. Here is the cartilage. Here, this is not a tendon tear. It's just part of the muscle fibers or muscular tendon junction, or it may be from fibers coming from a different direction. This little black line here is the bursa. It's less than 1 millimeter thick here. So try injecting that blindly without ultrasound. What are your chances? So that's what you can see here, the fibers are nice and regular and parallel. This is a really healthy tendon. If you want to look at that tendon in cross-section, so let's say you're going to take this cross-section from here, which is relatively more proximal, then you're going to rotate the probe around 90 degrees, pointing towards the ipsilateral nipple, and this is what you're going to see. You're going to have a uniform thickness of the tendon. The humeral head's here, and the cartilage is here, and the bursal side is here. So that's a short axis view of the supraspinatus tendon. If you were to take this view, a short axis view, more laterally or distally, then this is what you're going to see. So you're going to see these facets, the superior facet and the lateral facet. And on the superior facet, this is where the supraspinatus will insert. And the lateral facet is where the infraspinatus is inserting. So if you've got the tendon here like this, and you're going to, the probe is sort of like this. So at the more distal aspect of the tendon, it's down here, you're going to see this is where the supraspinatus is inserting, and more proximally is where the infraspinatus is coming from the back and inserting onto the lateral facet. So I want to define a tear, what sort of tears there are. A full thickness tear has nothing to do with the width or the length. A full thickness tear describes the depth. In other words, it goes all the way from the dorsal side of the tear of the tendon to the articular side of the tendon. If it involves this area, this is not classified as part of the tear, and you don't measure that as part of the size of the tear. So if the tear involves this whole depth, that is a full thickness tear, but it has no connection to the width of the tear or to the length of the tear. So someone may have a full thickness tear, but only a few millimeters thick, like 5-6 millimeters thick, which may potentially improve with injection of platelet-rich plasma. So it doesn't mean not all full thickness tears must go for surgery, especially in the older people. But so this is the defines of the tendon, and we're talking about this area here. So an articular sided tear is where you have the section closer to the cartilage where this is sort of torn, and you will see an area of anechoic area of disruption of the fibers. You may get retraction of the fibers here. And these sort of tears occur in the more elderly population. And these tears actually have a better prognosis than the bursal-sided tears, which occur obviously in the bursal side. And eventually you see this dip in the bursal surface of the tendon developing with fluid accumulating here in the bursa. And these tears are more common in athletes and have a poorer prognosis. You can also get interstitial tears where you just have a few fibers tearing down the middle, and they're not considered not articular and not bursal, and these are much rarer. So here's the subscapularis. Basically the same principles apply in terms of the depth. This is a long axis view. Now you know that the subscapularis is coming across the scapula, the front of the scapula, behind the rib cage, and inserting onto the lesser tuberosity. So the fibers are coming across this way. So if you want to check the fibers in long axis, you're going to have the probe held in a transverse position. So if we took this is sort of zoomed in a bit, so we can't see everything. But if we took that probe a little bit more laterally, you will see the bicipital groove. And if you took that probe a little bit more medially, you will see the coracoid process here. This is the subscapularis tendon. Again, nicely uniform, thick, and it's sort of thinning out here as it inserts onto the lesser tuberosity. If you want to look at that in short axis, you will have the probe held vertically. So it's a little bit confusing. And what you will see is all these clefts. Now, these clefts are not tears, because what you're seeing are a whole of little bundles, sort of bundles of fibers going across. So you'll see all these bundles. So in between the bundles, you'll see these clefts. These are not tears. These are normal, healthy bundles of fibers with these clefts in between. And that's normal. So this is short axis. The infraspinatus, this is my shoulder, quite proud of that. So here is you holding the probe just underneath the spine of the scapula, inferior to it, slightly up or horizontal, whichever. And you can see here is the muscle of the infraspinatus. Here is the deltoid, and here is the glenoid. Here is the labrum. Here is the intra-articular space. If you want to inject intra-articular, you can come in from this direction or from this direction. And then this is the capsule here. Here is the capsule going across here. And this is the capsule combining with some of maybe the inferior glenohumeral ligament. We said that the inferior glenohumeral ligament is the only one that goes posteriorly. And if you were to take this probe a little bit more laterally, you will see the tendons of the infraspinatus sort of fitting out as it inserts onto the lateral facet. So I'm just going to show you a few pictures of patients that I had treated. This is a guy. These are pictures of a guy who's 33 years old, who worked as a guard on a nearby village right next to us, who was injured by a terrorist. He was shot in the left shoulder, and you can see a fracture here. The bullet went through the supraspinatus tendon. It fractured his greater tuberosity. It came out of the infraspinatus tendon, and it actually tracked across the back of his shoulder girdle and landed up just posterior to his cervical spine. Quite amazing. And he came out of it okay. But here you can see here, it's actually a little bit masked, but you can see here that there's a tear here, almost full thickness, going across here and also across here. And there's this fracture here. Taken in short axis, you can see this fragment here. So underneath that, you can't really tell anything because it's always going to be anechoic. But you can see an almost full thickness tear going all the way up there. Maybe it is a full thickness tear. Sometimes you can see these better in short axis to define whether it's full thickness or not. And he presented to me 6 months after the terrorist attack. He had 2 treatments of prolotherapy injections of 20% dextrose. And you can see this is after 2 treatments. This is 3 months after the first treatment. You can see that you've got nice new collagen fibers filling up that gap. They're not mature yet, so they don't look as dark as the mature ones. The fracture seems to heal. And here also, the gap's basically filling up. The fracture's healing. So, and here's a picture of a guy who had a 9mm tear in the subscapularis, not from a bullet. And here he had injection of 20% dextrose into the tear. And you can see that is filling up. You can see, by the way, that there's the coracoid process. So that gives it away. If it wasn't for that, you would wonder, wait a second, is this the subscapularis or is this a short axis view of the supraspinatus? But the coracoid gives this away. So the rotator interval. So I promised I would elaborate on this. Here is the greater tuberosity. The greater tuberosity looks usually more round than the lesser tuberosity. So I'm coming in. It's a little bit sort of probably at the verge where the intra-articular is becoming extra-articular biceps. So I'm coming in from the lateral side. I'm injecting onto the greater tuberosity here, some of the fibers of the supraspinatus. I'm pulling out a little bit. I'm injecting into the lateral fibers of the coracohumeral ligament, pulling out a little bit, injecting a little into the biceps, pulling out a little bit, injecting into the superior glenohumeral ligament, pulling out a little bit and redirecting to the middle fibers of the coracohumeral ligament and pulling out and then into the subscapularis insertion. So I'm injecting 5 points with one jab. And this does a lot to just stabilize that whole rotator interval. And here is the acromioclavicular joint. put the probe just sort of across the top here, and it's very superficial. I'm talking about 1 centimeter under the skin. Here you can see that there's an effusion here. Here is the capsule of the joint, and it's very easy to just sort of go underneath the probe and into that joint. Not to inject much. You don't want to inject too much and stretch the capsule even more. You need a very small amount, no more than 1 cc. So I talked about releasing the tight scapulohumeral muscles when they are tight. So here is, I'm just dry needling these muscles. Research has shown that it's not really any less effective than injecting steroids or local anesthetic or sterile water or saline or Botox even. The advantage of dry needling is that you can just be very methodical, because you can do 5-10 needle muscles in one treatment, and you don't have to worry about overdosing on anything and causing anyone Cushing syndrome. So here I'm needling the rhomboids minor and then the rhomboids major, and I would needle just under where that my hand is, the levator-scapular muscle here. And here you can't really see it so well, and it doesn't look very, very safe, but it actually is safe, and I'm needling the upper trapezius muscle. It's very much zoomed in, so it looks very deep, but it's not, it's fine. And that's worth going to a course to learn how to do, because there's a lot of tricks to learn how to do this really well and properly. But what's amazing with this is that you get results within seconds. Within seconds, you get a really good range of motion. That's really complements the treatment that we do with regenerative therapy. We want to sort of release the scapular muscles. We want to improve the scapular motion, and this is part of treating the whole complex. Exercises. This is the second last slide. We talked about the importance of strengthening the infraspinatus. So this is a very good muscle that I'm taught. This is Shoulder Salmon, Professor Shoulder Salmon teaches. The advantage of using this way instead of just sort of this exercise here is because when you do that, if you just measure one of your partners and just laterally rotate this way, you will feel that the scapula is actually moving also. So if you want to totally isolate the infraspinatus, you just do this, and you'll see that the scapula is not rotating. This just strengthens the infraspinatus. And you can ask the patient to take a kilo of flour or a kilo of sugar or something and just sort of do this. And I often see my patients in the corridor and I ask them, are you doing your flying exercise? Sort of like that. The other exercise to do, which is very important, is the pec minor. And this is actually very challenging. You have to be very, very perseverant to do that a lot. And sometimes it's the anteriorly tilted scapula is irreversible, because especially if it goes together with a thoracic kyphosis. So there are lots of clips on YouTube on various techniques of pec minor release. Make sure you prescribe pec minor and not pec major, although that can also be of use. But pec minor is the most important one of those two targets. So the most important message that you can take home when treating any musculoskeletal pain is, first of all, to follow a very methodical assessment, including whether regarding the shoulder, to look at the neck, the shoulder, address the other three joints of the shoulder girdle, to address contributing postural and ergonomic factors, to consider that multiple pathologies often coexist, especially when pain becomes chronic. You get a lot of compensatory mechanisms when you're treating the lower limb of different limps and using the other joint, other limb to weight bear, or in the shoulder you're using the other arm. You're recruiting your scapula wrong. You strut differently. You're shrugging instead of doing this. You're doing all sorts of compensating mechanisms that can. They in themselves can cause pathology and pain. So we have to address all these and try and correct as much as we can. We're not God, but we can try and do our best. And to treat just the whole functional unit, to try and be as methodical, and not necessarily all with injections. You can do prescribed exercises, you can do dry needling, you can do hydrotherapy, you can use a whole whole bag of tools to treat these problems, as long as you don't use steroids, because that will neutralize your regenerative treatments. But basically, to treat the whole functional unit, and not necessarily all in one go, in the course of a few treatments, and you will get much better long-term results, and the patients will be much happier for it, and you will get a lot more satisfaction. So if you want to find out more, leave comments on the YouTube, or if you want to try and find me on about this course in Bangalore, you can also respond to me in YouTube, and I'll send you a flyer and information about it. And it would be great to see you there. It's going to be a really fun course. We've got fantastic staff, really top-notch staff. And India is a great place to visit. And March is a great time, and Bangalore's a beautiful city. So come and join us. It's going to be a lot of fun.